Hello again, everyone. This is Megan Leo. I'm going to bring you through our orientation for eFAST. So eFAST stands for the Extended Focus Assessment with Sonography for Trauma. And we're basically going to be doing this exam when we're evaluating patients with blunt or penetrating trauma to the chest or the abdomen. And the objective is to detect free intraperitoneal or pericardial fluid in the setting of trauma. The extended piece was added a little bit after the FAST was first described, and that was to reinforce the fact that we're also looking up in the chest cavity for intrathoracic fluid and pneumothorax. So this is what free fluid will look like on ultrasound. We went through this in the physics section last lecture, how fluid will look more dark because it's highly absorbed sound. So we're going to be looking for these dark, sharp lines as a sign of free fluid within the abdomen or within the chest. So in the setting of trauma, until proven otherwise, free fluid is hemorrhage. So that is why the FAST is so important to get done quickly and but also accurately. So as you get better at ultrasound and you're incorporating multiple views into your assessment, it's been described that ultrasound can detect as little as 300 milliliters of free fluid within the peritoneal cavity. So here's an example of a positive left upper quadrant. You can see here that, I'll zoom in here a bit. Here's your diaphragm, this bright white structure here. This is your spleen. And then where this yellow arrow is pointed is fluid in that subphrenic space. Now, in addition to detecting free fluid within the peritoneal cavity, ultrasound can also detect as little as 20 milliliters of fluid in thoracic cavity. So, this is even more sensitive than a chest X-ray. So here's our image again that we had just viewed. And as you can see here, in addition to that fluid that was up here in the subphrenic space, we also have fluid in the peritoneal cavity there. You can see how that's disrupting the mirror image above the diaphragm, and there's hypoechoic fluid there. Now to do our FAST, we're going to be using the curvilinear transducer. So remember, this is the low frequency probe. This is going to be able to penetrate deep into the abdomen to get those deeper structures. So we're going to be, for the right upper quadrant, we're going to have the marker towards the patient's head or towards the patient's right at all times. Now for the right upper quadrant view, we're going to be in this coronal position, as you can see on this model. And the arrow signifies where our marker is pointed. Now, as we go through the FAST, we're going to be talking about 4 main areas to evaluate for free fluid. And it's a little busy of a slide only because I wanted to emphasize the fact that in this right and left upper quadrant, we're not just getting one view. There's 4 areas that we need to evaluate and say in our minds whether we've seen fluid there or not. So this is not just a stagnant, let's find Morrison's pouch on the right. We're really looking above the diaphragm in that right pleural space, below the diaphragm in that subphrenic space. Then we move into Morrison's pouch, and then we slide even more inferior into the right pericolic gutter, inferior tip of the liver. Same things happening on the left. Those 4 areas are explored. Then we go to the suprapubic area to look behind the bladder for free fluid as well, and then move up to the subxiphoid space. And the extended piece of this is that we're also going to be evaluating for those pleural effusions, but then in addition to that for pneumothoraces. So again, back to our right upper quadrant view, we're going to be visualizing the diaphragm and Morrison's pouch initially. This is around the 8th to 11th rib marker towards the head, and this is our ideal image here. So the arrow there is pointed towards the diaphragm. We've got the liver, the kidney, and then if you remember in our physics lecture, we had talked about how the diaphragm is a strong reflector. We have a mirror image here. you can see that this spine signal stops at the diaphragm, so that's a good indicator that there's no fluid up in that pleural cavity. So here's a video of a right upper quadrant assessment. So I'm going to zoom in here a little bit. You can see that the diaphragm here with spine signal. The spine doesn't go above the diaphragm, so it looks like this pleural space is okay. There's nothing in the subphrenic space. Morrison's pouch looks good, but then let's let the video continue here. Sorry, I'll have to go back. So the point I wanted to make off of this this slide here is that if we let it play back, there's going to be a little bit of free fluid on this image. I'm sorry, I'm not able to freeze it where I want to, but if you look right up in this area at the tip of the liver, we're gonna see that little bit of free fluid. Let's let it roll again. And you can see right there at the tip of the liver, there's a tiny bit of free fluid. So that's why it's really important to focus in on all four areas of the right upper quadrant. So yep, right here. All right, so let's move on. So we'll go up to the left upper quadrant now. We're kind of the same concept. The tricky part about this left upper quadrant is that you're going to really need to have the probe close to the bed. So we even say knuckles to the bed, really getting posterior on the patient to image through that spleen. This is again is the 8th to 11th rib. Marker is towards the head, and we again are trying to get quite posterior to get our window through the spleen. So here again, there's our diaphragm where the arrows are. When we're assessing for free fluid here, we're going to again be looking above the diaphragm, below the diaphragm, splenorenal pouch here, and then also in the inferior aspect of the spleen and into the left pericolic gutter. So here's a nice normal view of the left upper quadrant. We have our spleen here and kidney. Here's a nice mirror image with the diaphragm. So above the diaphragm, below splenorenal, and then also moving inferiorly. Here's a nice example of free fluid in both the peritoneal space and the pleural space. So the pleural space is probably quite obvious to everybody. The key here, and the point that I wanted to make with this this video, is that sometimes it is hard to tell where the fluid actually is within the cavity. So the key is to find this diaphragm, and that's going to be able to differentiate whether this is pleural fluid or peritoneal fluid. So you can see there's fluid on this image in both the subphrenic space and in the splenorenal space there, in addition to the pleural space. All right, so now we move down to our third area, which is the pelvic view. So we're going to be talking about the anterior-posterior cul-de-sac. In males and females, these have a little different names, just whether there's a uterus there or not. So rectovesicular pouch in males and pouch of Douglas in females. So we're going to be looking both in the sagittal view and in the transverse view. And in the male, we're going to be imaging the prostate and then the rectovesicular pouch. It tends to be more off to the side, so let me just make a point here. There's off of the prostate, just above it, you'll start getting into seminal vesicles, which is kind of this hypoechoic area here. So you really shouldn't be looking for fluid right in between the prostate and the bladder. It's really going to be off to the sides here. That's a common pitfall to avoid. In the sagittal view, we're going to be trying to identify the pubic bone and prostate, and then the rectovesicular pouch is just behind there. So free fluid would be kind of in this area, and then you'd be looking up into the anterior aspect of the bladder as well. So here's a nice video of somebody fanning through entirely. This is another important point to make, is that In each of these views, you really want to scan all the way through the image to the point where it disappears and then come back all the way through in the other way. So then you've really interrogated the full space. Here's an example of female anatomy. So again, in the transverse view, you're going to really be looking on the sides of the vagina or uterus for free fluid. And then in the sagittal view, so just to kind of put this in perspective here, this is going to be, this is head, and then this is feet. And we're going to be looking for these important landmarks before we call free fluid or not. So vaginal stripe is shown here. You've got your anterior cul-de-sac, which is between the uterus and the bladder there. And then here's your posterior cul-de-sac. Now, a little bit of fluid back here in this posterior cul-de-sac is okay. That can be physiologic in a young woman. In trauma, you want to be a little careful about that. But as this fluid comes up, more than halfway up the body of the bladder, that becomes more volume than is acceptable for physiologic fluid. So that you really want to be careful about. And then any fluid you see in this anterior cul-de-sac in a female is abnormal. So that you can't call physiologic fluid. So here again is a very nice fanning through both ways. You're really interrogating the full area here, looking for free fluid. Here again, we talked about this in the physics lecture, is posterior acoustic enhancement. Now this is where this artifact becomes clinically quite important, and why that time gain compensation or FAR gain is important. It's really would be tough in this image to be able to tell whether there's a little bit of free fluid back here. There's just so bright and washed out, you can't really see the contrast. So you'd want to dial down your FAR gain, decrease that posterior acoustic enhancement to get an adequate assessment. Okay, so the last view we moved up to is the subxiphoid view. So we want to be transverse on the heart here. We're going to be putting the marker towards the right of the patient and then angling the beam. So if you think of the probe as a flashlight, you can zoom in here, and the ultrasound beam is going to be coming out kind of like this. So you want this ultrasound beam to be pointed kind of up towards that left shoulder. That'll give you a good axis to get some nice images there. And when we're assessing for free fluid, we're going to be looking for pericardial effusion. So in this this example, there's a pericardial effusion right here. In the setting of trauma, that's obviously going to be very important for your surgeon to know. So just to get a little bit of the anatomy down for these subxiphoid views here. Here is the subxiphoid picture. Here we have a video of a small pericardial effusion. Let me just go back to our image here so you can get an idea of the anatomy. So we've got the RV, which is most anterior. We're going to be imaging through the liver. LV is just below there, RA, LA, and we're going to be looking at both the inferior and posterior aspect of the heart. So this is inferior and this is posterior. All right, so again, here we are with our small pericardial effusion. You can see that just anterior there. In the setting of trauma, this is going to be important. It's going to be subtle, but you know that, especially in an unstable patient, that's going to help your surgeon know which cavity to open first. Now, thoracic ultrasound, we've looked for pleural effusions. We also want to be assessing for pneumothoraces. So ultrasound is very sensitive for this. It's been documented in the literature from anywhere from 92 to 100% sensitive for pneumothoraces. It's best to use the linear array probe, so we're going to be switching from the curvilinear to the linear array probe to be able to get some really good resolution on that pleural line, be able to see it clearly. You're going to be imaging both sides of the lung in the mid-clavicular area, anterior chest, just above the level of the nipple there. And what you want to see are two rib shadows, and you want to observe the lung sliding back and forth some people describe it as ants marching. Those are your reverberation artifact comet tails that are reflecting off of the pleural line. You can also use the M mode to improve your sensitivity, repeat in a few intercostal spaces as well. That's all going to improve your sensitivity. This is an example of the seashore sign in a normal lung sliding. So, again, we're taking along this line, we're tracking the motion over time at that area. You can see that here there's some movement back and forth, so that's indicating normal lung sliding. And then these lines here are just the stagnant chest wall. So this is a normal tracing here. Here's an example, a video of somebody doing the M mode function across the pleural line there. So again, you see we've got this nice seashore movement down there of the pleural line, and then up here is your chest wall, which is not moving, and that's why it's just a line across. Now, if there's no lung sliding, you're going to get this pattern. It's called a stratosphere sign. So some people call it barcode, but you can see there's an absence of that sliding down in this field. So no seashore. You've just got your stagnant stratosphere sign. Now the lung point sign is another thing we need to mention here. So this is the interface between the pneumothorax and normal lung sliding. So it almost looks like a serpent's tongue, or they call it the lung point sign. It's very specific for pneumothorax. So if you search around in multiple lung fields, you may be able to find the actual interface in the pneumothorax, and some propose you could even measure or quantify how big the pneumothorax is by identifying this lung point sign. All right, so that's it, everybody. Remember that for these 4 main areas of the FAST, plus the thoracic cavity, right upper quadrant, there's, again, within that, 4 areas we want to explore, above the diaphragm, below the diaphragm, Morrison's pouch, and the inferior tip of the liver. Then the left upper quadrant, we're doing the same. We're looking for all 4 of those areas. Then we've got the suprapubic, the subxiphoid, and then again our pneumothorax and chest assessment. All right, thank you.